Thank you. So I'd like to welcome you all to Australian Federation of Medical Women's Open Forum evening tonight, and we have an esteemed guest with us this evening, Professor Caroline De Costa, whom I have the great privilege of having met personally and having lunched with on occasion. And she has recently launched her 15th book as a retired obstetrician and gynaecologist with a wealth of experience and insight into the profession and being a medical woman. I'd like to acknowledge the traditional owners of the land on which we're all living on and enjoying the benefits and fruits of, and pay my respects to elders past, present and emerging. And just a few little housekeeping rules, if we can each, because this is going to be interactive, of course, after our initial sort of introductions, and then once Caroline gets started, if we could just be on mute, and then we can unmute and have a conversation, and I'll be asking a few questions, but please add the questions into the chat. If we're a smaller group, we do have quite a few registered for the evening, but if the others end up not being able to arrive on time, then you might just want to put your hand up if you want to ask a question. Alternatively, just put it in the chat and we'll select the questions out. So without further ado, I'll introduce Professor Caroline De Costa, who's spent some time between Melbourne and some time between Cairns over the past couple of years, and she is currently a research professor at the Cairns Institute, James Cook University, and she was the first professor of obstetrics and gynaecology at the James Cook University College of Medicine, Cairns Clinical School from 2004 to 2021. So the first woman to be appointed to such a role in Australia, and she graduated from the Royal College of Surgeons in Ireland Medical School in Dublin in 1973. Caroline subsequently gained both a Master's in Public Health and a PhD from the University of Sydney, and the fellowships both from the Royal College of Obstetricians and Gynaecologists and the Royal Australasian and New Zealand College of Obstetricians and Gynaecologists. She's practiced obstetrics and gynae in Ireland, the UK, Papua New Guinea and Australia. And Caroline's main interests have been in obstetrics, obstetric epidemiology, the healthcare of Indigenous and newly arrived immigrant women and refugees in Australia, contraception, abortion care and Caesarean section. She has published more than 100 peer-reviewed research papers. Caroline has also published many opinion pieces on women's health in journals such as The Lancet and Medical Journal of Australia. Caroline is the author of a number of textbooks and books for women about their health, and she is currently the editor-in-chief of the Australian and New Zealand Journal of Obstetrics and Gynaecology. Thank you so much, Caroline, for giving your time to be with us this evening. So we are looking forward to hearing about your story from your angle and your perspective, and share with us what wisdom you want to share this evening, and then we'll take it to the floor and ask a few questions.
Thank you very much, Magda, and thank you very much for the invitation to speak. I'm going to meet you all, and yes, I hope it's going to be a two-way conversation. As Magda has indicated, I aspire to be partly living in Melbourne, and I have somewhat achieved this aim, or I had, and I was developing a habit of lunching with Magda and Helen O'Connell, which has sadly fallen by the wayside. I just happened to be in Canberra when you had the fifth lockdown, and I had taken just enough clothes for 2 days, and then I realised it was not going to be a good idea to come back to Melbourne. So I've been couch surfing really since then, in May, more or less, and I did make my way back to Queensland once I had spent 14 days out and could prove that I had a Queensland driving licence. So I'm looking forward to coming back to Melbourne, and that lunch we've postponed several times now, Magda, is there somewhere.
Yes, I'm here.
I've followed the lockdown in Melbourne, particularly. I've got 2 children down there who were through it last year. So we've been very lucky in Queensland. We've also had a fairly determined premier keeping the Southerners out. Apologies for that, but that's how it's been. But I do look forward to something resembling normality later in the year, and I'm sure you all do too as well. So I think the plan is that Magda's going to ask me some questions.
Yes, I will ask you the questions. So Carolyn, can you tell us about your early life, where you were brought up, and your early days as a medical student?
Yeah, well, I can tell you a bit about it. I was born in Sydney and I was brought up in Sydney. And I started medicine in 1964 when I was 16. I finished first year, and I didn't know whether I wanted to be a doctor. I was far too young to be in the university. And so essentially what happened is that I deferred at the end of that year and began to work, and then I was able to travel. I found a job on a freighter so that I could work my passage, and I ended up in Europe, and 2 years later I was accepted into medical school in Dublin, and I finished that time. I did 6 years, a 6-year undergraduate course at the College of Surgeons, as Magda has said, and then I went to Papua New Guinea for my internship, and by then I was married. I had 2 children. I came back to Australia, to Sydney, for 6 months and did my first part of my MRCOG. That was 1974. And at that time, there was no Australian college. And I passed that exam, but I found it impossible to get a job as a woman in training in Sydney. So I went back to Ireland for 3 years and did the MRCOG from there. And I worked on the National Health Service as well. And then I went back to Papua New Guinea as a senior registrar. Encountered quite a number of difficulties as a woman working there, and came back to Australia for 17 years in Sydney as both in public and private obstetrics and gynaecology, mostly in Western Sydney, always wanting really to work in a more, challenging, non-urban situation, which I have discovered in Cairns. I started doing locums here in 1994 with Professor Michael Humphrey. Some of you may know of him. He set up the outreach program from Cairns Hospital, whereby the FROGS, the Far North Queensland Regional Obstetric and Gynaecological Service, flies in for several days to centres all over the Cape York and the Torres Strait, or Thursday Island, and provides services based back in Cairns, but a lot of minor consultations and minor surgery and so on can be done with FROGs, and so women don't have to travel. And I've been here ever since, and JCU was established with a medical school here in 2000, and I was fortunate enough to be appointed. So that's it all in a nutshell, Magda.
Right.
Right now.
Yeah, so it looks like, what took you back to Ireland was work and the unavailability of work for a female obstetrician gynaecologist here.
Yes, well, I thought, having got the part 1 of the MRCOG, which we had to do at that time in Sydney at night, because it was happening in London. We were doing the same exam as in London. And they didn't want the possibility of us transferring information about the paper. I'm not quite sure how it would have worked. At that time, of course, there was no internet. The phones didn't work very well. There were telegrams, but the idea that we would share information, it would even be possible, was ludicrous. So we started the exams anyway in the Bosch Library of Sydney University at 8 p.m. On a weeknight, and we finished at about midnight in order to be on Greenwich Mean Time.
That's some mean Morse code that you might have been using.
Oh, that's right. Yes, carrier pigeons.
So, what was studying medicine in Ireland like? What was Ireland like back then?
As a student, it was wonderful. Oh, it was great as a registrar too, and as a house officer. Dublin was full of students. There were quite a number of institutions apart from the College of Surgeons. There were 3 medical schools, the Catholics, the Protestants, and the College of Surgeons, which was neither. And there were a lot of international students there. There were other institutions as well. There were some very good pubs. It was quite cheap to live in Dublin as a student. So there was it was a poor country. There were many, many things wrong with the way society was organised. And fortunately, there have been changes, dramatic changes in Ireland since the 1960s when I began medicine there. But it was a great place to be a student.
And why did you choose obstetrics? Why didn't you choose another sort of specialty or general practice, which a lot of women did choose in those days who studied medicine?
Well, I think I became involved with the Irish Women's Lib organisation, and there were many things wrong with the situation of most Irish women. They had very little control over their lives, and particularly over their reproductive health. And it was illegal to use contraceptives. They were not available for most of the population. And of course, abortion was completely out of the question. And as a student, I saw women coming as a medical student and also as a registrar, women coming back year after year. It was quite common to see women who had 10 or 12 children and who were quite frank about the fact that they would have preferred to have had a lot less.
And what was your involvement in the improving women's reproductive rights and healthcare as a student and a younger doctor? So how did you get involved in that?
Well, some of it was campaigning and some of it was smuggling. So I had a baby. I became a single mother, somewhat related to the lack of contraception in Ireland at the time. But I continued with the pregnancy and had my son. And this very wonderful doctor, Rory O'Hanlon, looked after me, and he would take no fee. But he said, when you go over to London, as students, we used to go to London quite a lot because there was a Friday night boat to Holyhead and then a train. It was not expensive. It was not terribly expensive, and come back then the same way on the Sunday night. And he said, I'll give you a script, he said, and could you get some intrauterine contraceptive devices? I think they were copper teas at the time, and bring them back. He said, if I do it and I'm caught, I'll be deregistered and I'll be prosecuted, and I'll be very difficult for me, but you're a medical student. If they find them, they'll just take them away from you. So I said, of course. And I did it about 20 times. And I brought back 20 of the IUDs each time. I was never caught. And he was able to then give them to 400 women.
Wow.
In his practice. And the other thing one particular thing we did was that the Women's Lib organisation had a number of really well-known activists who were journalists.
I think you've frozen there, I think, Caroline. Might be... Is everybody else okay, or has just Caroline frozen? Yep.
Only Caroline's frozen for me.
Yeah, same.
I think I can see everyone else.
Yeah, sorry, Caroline, you're frozen. You might need to undo. You might need to stop your video and do the audio because you're in Cairns. If you can hear us, I might try ringing you. Can you hear us? So I think, yeah.
She's gone now, I think yeah.
Yeah.
Stop the video.
Yep. So there you go. I'll stop the video.
I'm going to have
Internet.
Yep. That's fine, Caroline. Yeah, these things will happen every now and then.
I think it's the Telstra here. I'm using my phone now as a modem.
Fantastic. That should work. So you were telling us how you were smuggling the IUDs into Ireland, and how you had the female journalists who were also activists around that time supporting the women's liberation movement there.
Yes. So 47 of us went to Belfast and bought condoms, and we tried to get the pill. The problem was the thing that we had to do was go through the Irish customs when we came back in the train station, and a great deal of publicity had preceded this event. And we went and got the condoms. It was a beautiful sunny day. Belfast was a great place to buy clothes. They were cheaper than in Dublin, so there were a number of advantages. And we went back. We were quite nervous, but the customs officers turned out to be much more nervous. And one of the problems for them was that many of them didn't know what a condom looked like. So they were pink with embarrassment as they asked us, have you got any of them things, miss? And we said, yes, and we had decided we're going to give them a few, but we're not going to give them everything. So they took these away and kind of corralled us into a space. The press were there. They weren't called the media at that point. Press were there, and it got a lot of publicity. And our names were taken and so on, but we were never charged. But the thing about it was quite a fun day, but it really began a discussion in Ireland about the need for contraception for married couples to start with, preferably married couples with children. Things had to move in small increments, but the Irish Family Planning Association was being founded then too, and I, as a student, I went to assist with clinics there, and you always had to know where the back door was in case you were raided. Unfortunately, never happened when I was there, but it did happen to others. And then when I went back to Ireland to do training in obstetrics and gynaecology there, I actually worked in clinics, and they were becoming well established then. That was the beginning of the transformation of Ireland.
That's really exciting. That is really exciting. So, undercover work, and then banding up with other, like-minded spirits, and setting up a whole new movement, which was really an undercurrent there anyhow, and the need was rife. It was really high.
And just as a footnote to this, I had forgotten all about the train. 2015, I got a phone call from a woman in Dublin who's a theatre director, and she said, we've made a musical. It's called The Train. It's about the train. And it was made by the people who did Riverdance, and it was fantastic. So I was invited to go to the premiere in Limerick, and then I went to Dublin with friends and saw several more performances of it. I couldn't stop laughing when she called me. I just thought, this is amazing. Then I thought, the next thing we need is a musical about IU486.
That's great. So how did you get along with your male colleagues in those days?
In Ireland, they were very well. They were fantastic. I was the second woman to ever become what was called assistant master, which was a middle grade registrar in the Cairns hospital, which is where I trained and where I've been a student. And they were extremely willing to teach me, and I never had any problems there at all. In the same thing also I found on the NHS, I didn't have problems. The first place I really had problems was when I went back to PNG as a senior registrar, and I'd been employed by the Department of Health to go and work there, and I was pregnant, and I had told the health department this, and I expected to have some weeks off, and when I got there, the director of obstetrics and gynaecology refused to have me working in his department when I was pregnant. So the health department ran around in circles a bit because I had a contract and I was expecting to work and be paid. So they made me director of casualty in Port Moresby General Hospital, which, as you can imagine, was not any less busy than being an obstetric registrar. And I was, less qualified for that, really. I hadn't done any general medicine for some time. And then when I came back to work, he was there, and he was hostile the whole time I was there. It was difficult to get any kind of surgical training from him, or it was difficult to get any words out of him at all. He was a real pain.
Mm. Well, female and a pregnant female at that in his domain would be really quite challenging, and you would have been the only one of your kind too. So doesn't excuse the behaviour, but it would have been a hugely difficult thing for him to get his head around, given what the culture was. Now, having told us something about your smuggling IUDs and condoms from London to Ireland, how did you get involved with the sexual and reproductive health movement in far north Queensland, for instance, and in Queensland where, termination was illegal until only fairly recently? The second last state to decriminalise.
Yes. Well, when I'd been in Sydney in practice, I hadn't seen abortion as a huge problem because there were a couple of good clinics. Preterm was there, and Bessie Smythe, and there was a clinic also run by 2 gynecologists in Westmead, separate from there. They were fellows of the college, but it was also possible to as an obstetrician and gynecologist myself, to perform surgical abortions in the private hospitals, not in the public hospital I was attached to. But I didn't see that there was a huge need. And of course, that was the 1980s. And medical abortion wasn't, it was just starting to be learnt about in the UK and in Australia. It was becoming available in France. So I didn't really see it. I was annoyed when the Harradine Amendment was passed, making it not possible to have mifepristone for Australian women, but I didn't have particular problems with my practice. It was when I came first to Cairns and saw how difficult it was for women in regional areas and rural and remote areas to access abortion. And I had direct involvement in a couple of cases where women had tremendous complications in pregnancies. And they said, oh, well, I had asked for abortion. I would have liked an abortion early, but I wasn't allowed to have one. And one particular woman said, my sister told me that there's a pill that you can get, and if you take it early on, it'll bring on an abortion. And wouldn't it have been better if I'd had this rather than having what was her third Caesar at around 26 weeks on the third Caesar, which was, as you can imagine, technically very difficult. The newborn died very quickly. She'd had 2 children already who were both intellectually and physically disabled as a result of very severe preeclampsia. And I just had to say to her, yes, and I'm going to look into this now and see what we can do, why we haven't got this. And I went to a meeting of the American College in San Francisco it was 2005. By then I was really thinking about the drug, and I had approached Ramscog and got no support for the idea. And that was when I felt we've really got to have that. We've got to have mifepristone here. They've got it in the United States. They've got it in Europe. They've got it in China. We have to have it here. So I became involved both in the campaigning. We already had the organisation that women here, some of you here may be aware of, Children by Choice. There had been ongoing activity to reform abortion law in Queensland for quite a long time, but it had been fairly marginalised. It became much more active once the OU486 campaign began. But just changing the law wasn't going to be enough. We had to make efforts to import it and use it, and that's what we did in Cairns. More to symbolise that it was possible than with the idea that we could do large numbers and still stay within the Queensland law at the time.
And how long did that whole process take?
About 8 years.
That's called tenacity.
9 years. Well, 8 years till we got the licence. Murray Stokes got the licence. It was great that the Murray Stokes organisation took it on because they had the clinics and they had the staff to collect the data, and they were able to fairly quickly have a study of the 13,000 Australian women who had successfully used the drug and shown that it was safe and effective and acceptable to women. And then there was no going back, no matter what Tony Abbott thought he might do or anybody else. It wasn't whether they're never going to take the right to medical abortion away now from Australian women. But the law in Queensland, as you've said, Magda, did not change till 2018. And that was another 8 years of struggle after that. But it's happened.
It's happened. And South Australia only end of 2019, I think. Yeah, they were the last state in Australia. It's a sort of a peculiar, it's really bizarre when you think that, Ireland of all countries decriminalised it way before we did.
Before Queensland, yes.
Before Queensland, yeah, pretty amazing. So you also have played a key and central role in bringing women into obstetric and gynaecology training programs. Can you tell us a bit about that?
Well, yes, when I came back to work in Sydney at the end of 1981 and found that I was one of 3%. 3% of obstetricians in New South Wales, of specialist fellows, were female in 1981. And I felt this has to change. There were other women gradually coming in, but it took quite a number of years. It took till the year 2000 for half the intake into training. The training's now 6 years. It's 4 years of basic training and then 2 years of branching out a bit. It took nearly 20 years for the training intake to be 50-50. And now it's 85% female and 15% male. And more than 50% of our fellows are women. And it's taken a while to get them into the various college committees and onto the college board, but I can happily tell you now that half the college board recently elected is female, and 70% of the council. And this is slightly embarrassing now for the college because they've got targets of 40% male and 40% female for the council, and then 20% either. But now they've got 70% female, they've only got 30% male. So there's a bit of discussion about what we're going to do about this. And really, I don't think anyone wants to see a situation where good male medical students feel that they cannot go through all that's necessary to try to get into training. And you have to prepare to get into training in any specialty. You've got to get the jobs, you've got to get the approval of consultants, you've got to pass exams, you've got to turn up at webinars and conferences and write papers and all that kind of thing. Who's going to do that if they feel, well, I'm not going to be able to get into this training because of my gender? Nobody should feel that.
I agree, and I think that it's a conversation that we're open to having, which is a conversation that was never even thought of 20 or 30 years ago, but we're also gender conscious now, and we've been on the receiving end of the inequity, so we're keen to not allow others to feel that same disenchantment with the system. So now, how do you deal with, you've been on so many committees, you've had a number of children, you've had a very, a prolific career, a research career. What about childcare, and how did you manage all of that?
Probably very, very badly, pretty ad hoc on many occasions. I did have, when I was in England, I had a nanny. Nannies were good nannies it was possible to find them. Naturally, they had to be well paid. So most of what I was married then, most of what I earned went to the nanny. The nanny was great. She stayed with us for the whole time we were in England. And she was trained. She'd been to nanny school, and she was, kind but firm, and very good for my children. And the other thing about both Ireland and England is that there were residences for students and residences for junior doctors in the hospital. So you were, although you were working very long hours and there was no paid overtime in those years, it was possible to kind of come and go from home, so I could keep an eye on things. So I've had good help there. I had good help in Papua New Guinea, and my children learned very early what obstetricians did. They have sat in tea rooms colouring or doing their homework and being fed raisin toast by midwives and cups of tea.
Was it a boy or a girl?
Yes, well, what my daughters used to go to a school where they had to be dropped a fair distance, and most of the time they got the train with big girls from the school taking them. But if I had a delivery at 7 or 8 a.m., it was too early for the big girls, so I would have to take my girls with me in the car, and they'd have to put their uniforms on in the car, knowing that when they got to the hospital, they would be in the care of, or they'd be in the midwife's tea room, and they would get much better breakfast, they figured, than they got at home. And they also would then, they'd have to write a note saying, why they were late. They would miss prayers, which they hated. And the best thing was that for them was that they might hear screams from the labour ward. And they could regale their friends with these terrible stories of what having a baby was like. So I used to have to kind of talk to them before I dropped them off and say, don't you go scaring people with this. She had a lovely baby.
That's a wonderful story. That's really evocative. I could see the look on the little children's faces, and then telling those gruesome stories back at school. So you've written a lot about caesarean section, and what do you think about caesarean section these days? What about the caesarean section rates, and how do you see that practice has changed in obstetrics over time?
Yes, well, certainly one of the things, I think that the most important thing I think that's changed, the most major change I've seen in the practice of obstetrics has been ultrasound. From when I was a student and in my first years as a house officer, we just looked at the outside of the woman's abdomen and palpated, and we followed various rules, and we did vaginal examinations to try and work out the size of the pelvis, which was all really just a lot of hocus pocus. Sometimes you were wrong. You could take an X-ray of the pregnant abdomen, just one, so that you didn't cause cancer in the baby, but we really didn't know what was happening. The caesarean section rate was about 9% when I began training, and now it's round over across Australia, across the whole country. Of course, it's around 33%, higher in certainly in private practice, a bit lower in some other parts of practice, but I think it has rather plateaued at around about 1 birth in 3. And in public practice here in Cairns Hospital, we do caesarean sections for good reasons, and we have a meeting once a week where we look back at the emergency Caesars over the previous week and see were there any we could have allowed the woman to go on in labour or have done something different so that she had a vaginal birth. And it's pretty rare to find one where you really think that shouldn't have been done. But there are equally a number of cases where there are women who you think, well, perhaps it would have been better if she'd had a Caesar or a Caesar earlier. So I think that we have reached in public practice a plateau. One of the reasons why we have more is that now than we did is that women are choosing to delay pregnancy until they're their careers have become established, or their lives have been have taken different paths until they decide to have children. The average age at first birth now, I think, is something like 32. It used to be 22 or 23 when I began in practice. And women are, I'm afraid to say, heavier, and they are more likely to have associated complications such as diabetes, gestational diabetes, hypertensive disorders of pregnancy, preeclampsia, and so on. So there are a number of medical reasons. They're also likely to have larger babies and have obstructed labour or delays in labour leading to caesarean section for the first birth. And we know that once a woman has a Caesar for a first birth, she's quite likely to have a second Caesar if she has a second child. And these are some of the things that are pushing the Caesar rate up. Another thing is IVF. IVF pregnancies are often achieved with great emotional and financial input on the part of the mother, but also of her partner as well. And I think there's a willingness to do a Caesar for a woman who's conceived with IVF that is greater than if she has conceived spontaneously, and often a wish on her part also to perhaps have an elective Caesar because she feels that this might be her only child. So caesarean section is one of the normal ways that women are having births in 2021. And I think we should be able to accept that, that women who make the decision mostly do it in conjunction with their doctors and midwives. Certainly for elective Caesars, that's the case. The woman should definitely be involved and understand what's being done and why, and know when it's going to be done, and that she can have a partner and she can have an epidural and as much input as possible. And women who have changes in their birth plans and have emergency Caesars, obviously you don't have the same time in which to explain the need, but you hope that women will have gone into the pregnancy and the birth well enough informed to understand that there is actually a change of plan, and that there will be an explanation postpartum as well about why this had to happen, and that will be as satisfactory an experience as possible for the woman.
Yeah, great. Well, we've got about 15 minutes to go, and I thought we might open it to the floor and see if you have any burning questions you'd like to ask Caroline around her career and around, life-work balance, around her book, her writing, her research. So, Desiree, you can unmute yourself and ask in person. I'd like to ask Caroline how she thinks midwives have changed and where they go now. Yeah. Thanks, Desiree.
And our relationships with them.
Yeah,
good question.
I've always had very good relationships with midwives. This began in Ireland when I had my first baby and I was a single mother. I discovered midwives. I didn't know anything at all about obstetrics and gynaecology, or I didn't know much about having a baby before I had one. And even then I didn't know too much. I had chloroform for the birth. That's how long ago it was. But the midwives told me what to do in the days in which I was lying in, which was, you got about a week after you had a baby because it took days. Back then there was not syntocinon in the quantities we have it now. A midwife took me to the front door with my baby wrapped up. She carried the baby. And when we got to the front door, she presented him to me and she said, "You'll be a good mother." And she said to him, "You'll be well looked after." And I was tremendously inspired by this. It was really heartening to me in the weeks it came. The midwife told me that I can do this. And I kind of feel pretty pro-midwife ever since. The midwives I worked with when I was training to do the MOCOG in the 2 Dublin hospitals I trained in were also extremely willing to share their knowledge. Midwives know a great deal. They don't know everything, as you and I know, Desiree, but I got on well with them. And by the time I came back to Australia, I was already a consultant. I didn't have to go through training here. I think things are a bit different in the tertiary hospitals for some people. I certainly have found the Cairns midwives very easy to get on with, but I have had to, when I have been in charge of my undergraduate students, had to approach the more senior midwives to make sure that my students, and particularly my male students, actually got the opportunity to be involved in labour and birth, because the younger generation of midwives come in with very fixed ideas about not having male students, not having male doctors, and so on. And there are attempts to define territory.
Well, I ask because, you know, you and I have sort of matured in our practice through this change in demographic for doctors, that's for starters. So I came through, it was 50-50 males to females in my medical school. And then, you know, the rising academia in nursing. And I kind of ask, because yes, look, I've got great friends who are midwives, but there has been, I think, a bit of a social change about that. And I just picked up really on where a woman's right to choose lies in that academic push to continue to focus on, you know, vaginal delivery rates rather than, I don't know what I think about it, but a woman's agency to also decide what's for her.
Yes, well, I think this idea of normal birth is not helpful. A definition from the WHO of normal birth as being between 37 and 42 weeks and starting spontaneously and proceeding spontaneously and birthing spontaneously with no damage and no need for epidural or regional analgesia of any kind. It's fine for those women who can do it, but it's not something that you can study for like an exam or prepare for a race. First of all, you've got 10% of women who are going to go into labour or have a decision made for delivery before they ever get to 37 weeks. And then you've got women with quite a number of complications of pregnancy who need to have, you know, labour induced, so they're not normal. You have women who have very good reasons for cesarean sections. You have women who have breaches. You have women who have twins. You have women who go past 40 weeks. So are they all abnormal? Using the word normal is not helpful.
It's broad, isn't it? Really, when you think about it, it's broad.
Mm. Yeah, I mean, there are lots of different ways to have a baby, and I think we should embrace them all.
Yeah, that's great. Yes, Miyuko.
I have a question. So you talk about the changing demographics and why we've had more cesarean sections in terms of having women having who are older in their birth, and also people who've had IVF and things like that. And you talk about your really interesting process of going through in Ireland with contraception and smuggling that, and women in rural areas not knowing about abortions and things like that. I've noticed in my age group, whilst everybody at school got like sexually transmitted infection and contraception advice, very few people know about infertility. And even trainees, when I've done rotations in obstetrics of gynaecology, they get very little information on fertility. At medical school, I didn't get a single class on infertility. And so I've just noticed that there's potentially now a new gap where it used to be kind of this miss of knowledge in terms of contraception and STIs, and now it seems to be more towards what happens if you can't get pregnant. Is this something you've noticed in your practices? Do you think it's a problem that people don't know about infertility and it's driving up other things?
Yeah, I think it is a problem. One of my JCU students, Nicole Cheung, did quite a good study looking just at that age group in Cairns, in JCU students who weren't medical students and our TAFE students and teachers, and found quite a marked lack of knowledge, a much rosier view of their chances of becoming pregnant if they waited till their later 30s. And it's not only careers, it's having a house, a mortgage, traveling, all those things that people want to very rightly want to do. And thinking, oh, well, then I'll get to the time where I can have children and it'll be easy. And if I can't get pregnant, oh, well, I'm sure there's IVF. But it turned out that the knowledge of these women was not nearly as great or as accurate as it should be. I'm disturbed to hear that you didn't learn about infertility in medical school. I can assure you that the JCU students learn about infertility. I won't ask where you went.
Biology aspects, but not like specific time frames and things like that. And I know that as colleagues, when they've asked to counsel patients on it, don't seem to feel like they know enough to be able to appropriately counsel patients and things. And not just from my medical school, this is my colleagues who've come from a range of medical schools.
Right.
I agree with you there, Miki. So in terms of women's health and sexual and reproductive health, that's one of the weakest subjects taught across the medical schools. And I attended so Monash has a group called it's called WISHM, Women's Health Interest Monash Students. And every year they have a session where they invite women's health specialists. I'm on that panel almost every year, have been with Susan Davis and a bunch of obstetrician gynecologists, but also, endocrinologists, GP. I go there as a GP, am invited to speak. And then we go into breakout rooms and they ask questions about, so how did you go into your women's health stream? And the education that they get around that is relatively limited. One of the things I've recommended to them, and it's something that you could also take back to students yourself, is there are some really amazing consumer information sites, which I think are fantastic for med students. They are the best. And I think the Royal Women's Hospital A to Z fact sheets, I think Your Fertility website, I'm an advisor, I'm on their board, but their website, it's a government website, yourfertility.org.au, has everything about how, preconception care, how you can optimise your fertility in males and females, linked in with Andrology Australia, now called Men's Health Australia. And for health professionals, for doctors and trainee doctors, there's a whole segment on you can go on the link and see, health professional information, and it's got a whole series of videos and webinars that you can just access and learn a lot. But I agree, training medical students has been really not, it's deficient in this area, very, very greatly so. So more work to be done there, Caroline.
Yes, not for me though. I'm trying to retire. There are a couple of questions on the chat which I just found. Should I?
Yeah. So Marjorie talked about the MTOP provision in rural Australia, basically, and where you are, Marjorie. If you'd like to sort of ask Caroline a bit about that.
What I've written is that medical termination of pregnancy, whilst it's really pretty simple to do, and with 3 or 4 of us trained in our general practice, there really is an equitable access to women west of the Great Divide in New South Wales. And I understand in Queensland, the Marie Stopes clinics have closed rather than maintained anyway. So for women, there seems to still be inequity of access for medical termination of pregnancy.
Yes, there is, and this is really the reason why I began trying to get mifepristone into Australia in the first place, so that it was available in regional North Queensland. And I might give a plug here for the Cairns Sexual Health Clinic under the very wonderful Dr. Darren Russell, who immediately once it was available, set up in the sexual health clinic an early medical abortion clinic, which now sees 700 women a year from the region and provides them with early medical, well, provided that they have understood and made the decision. About 500 of them do go ahead with an early medical abortion, and mostly the provision of long-acting reversible contraception. One of the silver linings of the pandemic has been telehealth, and the fact that there is now an item number for telehealth, and the fact that it is possible to do a large part of an early medical abortion using telehealth. And I think that is here to stay. And I've looked at a couple of papers in my role as editor, which you'll see coming through shortly, and I think also some in the MJA, about the effects of the pandemic on this. But even so, there are large chunks of regional and rural and remote Australia where women don't have a GP prescribing or a pharmacist dispensing mifepristone, and they are relying on telehealth to provide that service. And so, of course, they need to know about it. So it's as much women learning that the service is available, or that procedure is available, that process is available, and understanding it, because it is limited to the first 9 weeks of the pregnancy. And yes, the Marie Stopes have closed, or will next week close, the surgical services in both Townsville and Rockhampton. The obstetricians and gynaecologists of those towns have to step up and provide that service. That is what has to happen within the public sector. The public sector has, Queensland Health has understood that now that the law has changed, they have the responsibility to provide the service and make it accessible for women. And they are making really very good efforts to do this, or they were doing so in 2019 before the pandemic started. And there are now good guidelines for the provision of abortion in Queensland. And the public hospitals, though, in some places are outsourcing it well, particularly in the southeast, to Marie Stopes. We needed to start in medical school the education about abortion and about contraception and about reproductive health generally. But then it also has to be much more of the part of training for fellowship and diplomas in RANZCOG, and it needs to be part of the clinical experience, so that it's part, and for the RACGP as well, for rural and urban generalist training, so that it is normalised, the stigma is removed, and abortion is available. I understand that some people have conscientious objection to abortion, and I have no problem with that. But the majority of Australians don't, and the majority of doctors don't, or at least they are not anti-choice. And it's often just a fear of not knowing about the drug, the fact that it still has to, it requires online training, or the completion of an online module before you can be a registered prescriber of argufrate-6 of mifepristone is a barrier. There are a number of barriers there. So I think we're still working at it, Marjorie.
Mm-hmm. Now, Nicole asked if you could tell us a bit about Aboriginal sexual health in Far North Queensland.
Aboriginal sexual health.
Sexual health.
Well, yeah, yes, there are some particular problems in Far North Queensland with the rates of chlamydia and of gonorrhea and of syphilis. There have been in recent years a number of congenital syphilis cases where babies have been born with congenital syphilis, which is something that just should not happen in the 21st century. It should have been wiped out, syphilis from Australia, but it hasn't been. There are excellent Aboriginal community-controlled health organisations running services now throughout far north Queensland. But there are still gaps. There's no doubt that there are gaps, and there are gaps. There are statistically, the maternal morbidity rates are greater amongst Indigenous mothers than in non-Indigenous and so on. So further improvement is needed in our services.
Any other questions? Desiree asked if there's an issue with subcontracting TAP to med students. Could you clarify what you were meaning by that, Des?
Not med students, Murray Stopes.
Oh, Murray Stopes, because I thought it was
I
MS.
meant I was referring to the training or just the seeing of things, if it's always somewhere special.
Sorry, I don't quite get the question.
Sorry, I was saying that, do you think that when you said that southeastern Queensland is, subcontracting their termination services to Murray Stopes, that how that then impacts on training about what medical students and trainees
Well,
see
exactly.
in
Yeah.
the public hospital,
Yeah.
it's not normalising it, basically.
No, that's right. No, abortion is something that we don't do it in the hospital. We don't do it it's appearing in medical courses now, but it's taken a while to get that underway, and then they learn about perhaps, but they don't actually see women being counselled. They don't see them having the drug dispensed. They don't see surgical abortions because they're taking place off the hospital campus. And
they also don't do them then, do they?
No, they don't do them because they don't learn how to do it. But Dr. Mike Corrett, who did the first mifepristone cases with me, also provided surgical abortions in Cairns for many years in the day surgery here in Cairns. And he gave up his obstetric practice and he got very bored. So I gave him he became my senior lecturer, and he had an abortion at least once a week, the day surgery, and he offered to always have students there, but they could, if they had objections, they didn't have to go. We never had a single student decline to go. And when they went and they took histories from the women and understood why they were presenting, why they'd made this decision, they understood the need for the abortion service, and also the need which he provided for the reversible long-acting contraceptive that they left the day surgery with, or arrangements for. So hopefully those JCU students are now out in the community learning to become GPs or obstetricians or haematologists or any kind of specialty, but knowing that abortion is part of women's reproductive health care.
Yeah, that's a really important and very important point. It's part of women's health care. Yeah. So
things have got better over the last 20 years.
They have, but when we look at what's going on in the States and in Texas, it's pretty frightening. We're always on the brink of losing our reproductive agency, unfortunately. Yes. So and that's a disappointing reality, that we can never sit back and say, okay, we've achieved that and we can just sort of get on with life and everybody's on the same page. We never are. So that's but yes, we have to keep working at it and having these lobby groups and training. I think what you pointed out, Mickey, is really important, and also what you raised there, Desiree, is too, training. Yes, Nicole.
Can you hear me? I've got little earbuds in.
Yeah.
Yep. I actually grew up in the country. I went to Arakoon School as one of my 11 different schools I went to, and I love country practice. I lived up in Tamworth in northwest New South Wales. But then in the end failed because the area health service was difficult, and ended up in Canberra, but I haven't got it out of my blood. But I guess I'd ask Caroline about how do we link people up with country practice? I love living in the country. It's an amazing lifestyle. But how do we do it? Because my daughter wants to do medicine, but she's going to be ancient And I don't think she'll ever be able to do it. She'll be so ensconced in a city. She's 22 and on her honours, about to do a PhD, and then medicine, and then oncology training. She'll be too old to make a new life, presumably, if she's got a partner somewhere. How do we bridge this divide? How do we get people to go and experience life in the country, an ONG practice or whatever in the country, and encourage people to work there because it's great and we need it? But then all our medical students are old, like super old, and with extensive training for even GP practice now is extensively trained, and people just, I don't know, in their 30s and they're in their 40s. What do you think is the way forward, and what should we be doing?
Well, I think for the rurality, most medical schools now have rural terms that are fairly compulsory electives. JCU is actually a rural medical school, being in Townsville and Cairns and Mackay, but they also then go out to all the smaller places and they spend quite a long time every year from first year. But I think the fact that other medical schools also have now got connections with, for example, the Victorian medical schools all have, they have Shepparton. Shepparton is perhaps not the best example right at the moment, but Warrnambool and Mildura and I don't know where else, Echuca, have, they are smaller centres based around the hub of Monash or Melbourne. And the same is true in New South Wales. And that is done with the hope that they will see that rural practice is very interesting and rich, and you have more responsibilities really as a rural doctor of any kind, in that you need to know a bit more about particular things because you're going to have to deal with them yourself rather than hand them on to some other kind of super specialist. And the same thing applies to the training for fellows in RAMSCOG. There is a rural rotation in each of the states whereby the trainee has to go. People complain about those, but I think that those are very necessary, first of all, to provide the workforce, but also to show people that, yes, you can have as you said, you can have a wonderful life in a rural setting. And then I think we need shared jobs, shared trainee jobs, part-time work, the ability to take maternity leave. The harder thing is you've just touched on, Nicole, is if your partner is doing something else and isn't able to move to, Dubbo or Mildura with you, how do you manage? And I think, well, it's something you have to work out with them and meet halfway. But both of you, compromise has to be part of it. I don't see any alternative to that. But it is only for a fixed amount of time.
Yeah. Yeah, good points. Look, I think we're going to have to wrap it up. It's 8:40, and I know that we could end up, talking into the, for another at least hour. This is really intimate and very open. So thank you, Caroline, for your frankness and the stories you told us are really rich, and you've had a really exciting career and a very exciting path, which is inspirational for all, I think, and you've just done it all along the way whilst picking the big and difficult topics and issues to address and represent. So I congratulate you, we all do here, for your courage and just tenacity. So thank you for what you've done for women's health, and and for coming today.
Well, thanks, Magda. I've had a lot of fun and I met some really good people, and I hope it's not totally over yet either.
Yeah. So what's a pearl of wisdom you'd like to impart to us in closing today?
I think you just don't take yourself too seriously, and just particularly at the moment, just it's a matter of getting through each day at a time, isn't it, with this new stress upon us all.
yeah, yeah.
Reach out to your loved ones.
Thank you. Yeah, really, really very important. Thanks for that. That's a great note to finish up on. So I think thank you very much, everybody, for coming tonight. If you're not a member of AFMW, please check us up on the website, and do join. We have really wonderful events and connections with the international community too, and we host some really interesting sessions there too. And Carolyn, you're welcome all the time, anytime, to join us. And yeah, and I look forward to having another lunch with you in.
Yes. Thanks very much. Thanks, everybody.
Thanks a lot, everybody. Bye. Bye. Well, thanks everyone for coming. That was, I had a lot of fun. That was fantastic.